So prostate cancer is known to be a immunologically cold tumor where immune checkpoint inhibitors have very limited use, and their use has only been proven in a very small subset of patients, especially pembrolizumab, where the approval has been done in a pan-tumor setting in patients with a tumor mutational burden of at least 10 mutation per megabase. The Keynote 158 trial on which this approval was based did not have any prostate cancer patients in the high tumor mutational burden arm. For this reason, Dr. Graf and I sought to compare the efficacy of taxanes versus immune checkpoint inhibitors in patients with metastatic castration-resistant prostate cancer with a bi-tumor mutational burden.
Yes, of course. So this has been a collaboration between the group at the Huntsman Cancer Institute as well as Foundation Medicine. They asked us if we could use outcomes from our clinical genomic database to evaluate the outcomes of patients on immune checkpoint inhibitors in prostate cancer, as well as a comparison to similar patients who received standard taxane chemotherapy, who were of characteristics that would be somewhat consistent with the FDA label. We compared the outcomes of these patients using PSA response, time to next treatment, and overall survival. We observed that for patients who had low tumor mutational burden, that the outcomes were not any better on immune checkpoint inhibitors, perhaps worse. However, for the patients who had high tumor mutational burden, as defined by the FDA cutoff of 10, that the outcomes were observed much more favorable for PSA response, time to next treatment, and overall survival. Next, we say that before this study, it had been known that patients with high microsatellite instability, and there have been some signals that perhaps there might be some benefit in this patient population. However, no one had compared outcomes to patients who received chemotherapy instead, which was the default option for these patients in this clinical scenario.
Yeah, I hope that these results might provide some guidance to clinicians, as immune checkpoint inhibitors constitute a viable, less toxic, and more efficient alternative in these select patients compared to cytotoxic agents.
We hope that these results will be further validated in future studies, potentially in earlier lines of therapy, using these markers as selection for patients on those trials.